Is a continuation of the class yesterday. Yesterday, we started the class by doing the topic of growth and development. In growth and development, we talked about growth. We talked about the assessment markers of growth. I talked about the different markers that are used, age-dependent markers, age-independent markers of growth assessment. We talked about weight. We talked about height. We talked about head circumference. We also talked about mid-arm circumference and skin fold thickness. Then we talked about short stature. Remember? Now, yesterday I was going through some questions of FMG. In one of the question, they had asked, what is the best definition of a short stature? Now, I told you the definition of short stature is height of a child which is less than 2 standard deviation. Remember, I told you whenever the height of a child is less than 2 standard deviation from the expected. Now, please remember another way of saying less than 2 standard deviation is less than the third percentile. This was what was one of the options in that question, less than the third percentile. So either you can say height of a child less than 2 standard deviation, or you can say height of a child less than third percentile. Both of them are taken as the definitions of short stature. Standing height, I mean. Standing height of a child less than 2 standard deviation, standing height of a child which is less than the third percentile. So this is the definition of short stature. I hope there is no confusion. Standing height less than 2 standard deviation, standing height which is less than the third percentile. Then I told you there are two types of short statures: physiological short statures, pathological short statures. Physiological short statures, I told you when the parents are short, that type of physiological short stature is known as a familial short stature, also called as a genetic short stature. On the other hand, another type of physiological short stature is a constitutional delay. Why do we call it as a delay? Because the final height is normal. That is why it is not short stature. But there is a delay in the attainment of that normal height. That is why we say a constitutional delay. In a familial short stature, there is always a final height which is short. And what was the other difference I told you between familial short stature and constitutional delay? It's just a revision of what we did yesterday. The second difference was that the familial short stature is associated with puberties which always come on time, while in the case of a constitutional delay, as the name suggests, delay, constitutional delay, the puberties are also delayed. Right? Then pathological short statures, I told you, proportionate, disproportionate, based upon upper segment to the lower segment ratio. So when the upper segment to the lower segment ratio is matching with the age, this type of short stature is known as a proportionate short stature. When it is not matching, then it is known as a disproportionate short stature. I also told you when it is not matching upper segment to lower segment ratio, when it is not appropriate for age. Why is it not appropriate? Either the upper segment to lower segment ratio is more than expected. What is that type of disproportion called? Infantile disproportion. Or the upper segment to the lower segment ratio is less than expected. What is that type of disproportion called? Advanced disproportion. Infantile disproportion, I gave you the examples: achondroplasia, which is an orthopedic disorder. Then another example, untreated congenital hypothyroidism. So they might give or cretinism. Both of them are correct. This again is a question that I saw in the FMG while I was going through those papers. The question was, which of the following is an example of infantile disproportion? One of the options given was cretinism, congenital hypothyroidism. So that is your answer. On the other hand, proportionate short statures, I told you, are endocrinal disorders, chromosomal disorders. Again, an example of a question that I saw yesterday. Which of the following chromosomal disorders presents with short stature? The choice given, which was the correct choice, was Down syndrome. So both Down syndrome as well as Turner syndrome are examples of chromosomal causes of short statures, chromosomal disorders associated with short statures. Then systemic disorders and malnutrition. So I told you never to get confused if they ask you overall most common type of short stature in children. Answer should be constitutional delay. But the most common pathological short stature in children, answer would be malnutrition. Then we did milestones, in which I divided the milestones in gross motor milestones, fine motor milestones, language milestones, and social milestones. I again and again keep on repeating, milestones is something which you have to do on your own. You have to actually revise those milestones. My work was to tell you the milestones. Please remember, if you have 10 books, all the 10 books probably will give a different age to a particular milestone. So a lot of discrepancy, lot of differences between the ages. You have to follow something which is important. I think you should follow. Ghai is the best book. OP Ghai is the best book for following the milestones for your exams. And most of the notes that I have taken are taken from Ghai, OP Ghai. Last thing we talked about breast milk. So there were certain things I told you about breast milk. So I told you breast milk can be expressed and can be kept at room temperature for 6 to 8 hours. Can be kept in the refrigerator for about 24 hours, but can be kept in a freezer for 3 months. Now, in the options, that one of the questions I again saw yesterday when I was going through the FMG question, the question was, for how much time can express breast milk be kept in a freezer? In a freezer. So I told you, at room temperature 8 hours, in a refrigerator 24 hours, and in a freezer for up to 3 months. The choices they are given was 24 months, then 24 hours, 3 days, then 6 days, and 1 month. So 1 month was the maximum. So therefore, the best option was 1 month. But as I'm again and again saying, in a freezer, when the temperature is minus 20 degrees centigrade, you can keep the expressed breast milk for as long as 3 months. The breast milk will not be spoiled. This finished growth and development. Then we talked about neonatology. Neonatology, I talked about the length of a newborn, which is 50 centimeters, head circumference 35 centimeters, then the upper segment to lower segment ratio 1.7:1, then heart rate of a newborn 110 to 160 per minute, respiratory rate 40 to 60 per minute. I also talked about the child passing meconium. So the child passed meconium within 24 hours. If meconium is not passed within 24 hours, it should raise concerns, but you do not start investigation. When do you start investigation? You start investigation when the meconium is not passed for 48 hours. And meconium is passed till the 3rd day. What color is meconium? I told you yesterday, it is usually blackish in color. 4th and 5th day, the stool that is passed is a transitional stool, which is more of a greenish in color. After the 5th day, the stool that is passed is golden yellow colored stools when the child is on exclusive breast milk. The child should therefore pass meconium within 24 hours and should pass urine within 48 hours. Then another thing that I told you is temperature. What is the normal temperature of a newborn? 36.5 to 37.5 degrees centigrade. So hypothermia is when the child's temperature is less than 36.5. Hyperthermia is when the child's temperature is more than 37.5. Hypothermia further divided into cold stress, which is very, very mild form of hypothermia, very, very mild, 36 to 36.5 temperature. A temperature between 32 to 36 degrees is called as mild or mild to moderate hypothermia. And if the temperature falls to even less than 32, it becomes a very, very severe life-threatening form, which is known as a severe hypothermia. Right? So we discussed all these things yesterday. We are just revising them. Then what are the methods by which child loses heat? So the child loses heat by 4 methods. Coming in contact with a cold surface, conduction. Near a cold surface, not touching it, near a cold surface is radiation. Near a source of cool air, such as a fan. So if a fan is kept near a child, that fan can remove the warm air from the child's surface and make the child cold. This type of heat loss is known as heat loss by convection, so through a fan. And finally, loss through the skin is known as evaporation. The most relevant method of heat loss at birth is evaporation. Now again, among the questions that I was going through, FMG question, there was one question on incubator. So what is an incubator? It is basically a type of a device, a box in which you keep preterm babies warm. Now most of the current incubators have fans fitted in them, which can actually exchange the warm air inside the incubator and makes the child warm. So how are you exchanging the warm air inside the incubator? By fans which are fitted inside the incubators. So if fan is actually regulating the warm air inside the incubator, what do you feel is the mechanism by which incubators keep the newborns warm? It is convection. So most of the incubators, they work by the mechanism of convection. Fans which are actually exchanging warm air inside the incubator and therefore are keeping preterm babies. Usually preterm and very preterm babies are kept under inside the incubator for keeping them warm. Few more things that we did yesterday. The first thing that we did yesterday, the next thing that we did yesterday was about reflexes, neonatal reflexes. I told you Moro's reflex, I told you grass reflex, I told you asymmetric tonic neck reflex, I told you rooting reflex. All of them are primitive neonatal reflexes. Primitive neonatal reflexes are the reflexes which are present at birth. However, there are certain reflexes which are not present at birth, but they appear after birth. I gave you two examples. One is a symmetric tonic neck reflex and the other is a parachute reflex. Both of them are not primitive reflexes. So again, an FMG question, which of the following is not a primitive reflex? The FMG question is which is not a primitive reflex is a symmetric tonic neck reflex or is a parachute reflex. Now someone asked a very relevant question yesterday. I got a very relevant question yesterday on Babinski's reflex. Now I went through my notes also, I went through some books also. Please remember, Babinski's reflex is a type of a plantar reflex. So what is a plantar reflex? If you actually stroke the sole of the foot, even in the case of a newborn, what will happen? The fingers of the foot will fan out and there will be plantar flexion, some amount of plantar flexion. Now since this reflex, Babinski's reflex, since this reflex is known to appear at 18 weeks of intrauterine life, 18 weeks, and it disappears after birth, therefore it should also be considered to be a primitive reflex. Babinski's reflex is nothing but the plantar reflex. Plantar surfaces you are stroking, so that is why it is called as plantar reflex. Plantar means the foot, the underside of the foot. So Babinski's reflex or the plantar's reflex is a type of a primitive reflex. But yes, it disappears by around 5 to 6 months. If it is present later on in an adult, we normally check this reflex in an adult, and if it is present, it usually indicates damage to the corticospinal tracts. The pyramidal lesions can be diagnosed if Babinski's reflex is positive. Right? So with this, we have revised everything that we did yesterday. Now I start with today's class. And what I would start today with is umbilical cord. So umbilical cord is basically a attachment between the mother and the newborn. The mother and the newborn are attached by this, and this umbilical cord needs to be clamped and needs to be cut immediately after birth. An umbilical cord normally has two umbilical arteries and has one umbilical vein. So how many arteries are there? Two umbilical arteries, one umbilical vein. Another FMG question. Suppose you see after birth there is a single umbilical artery. There are not two. There is a single umbilical artery. There should ideally be two umbilical arteries. But suppose you see there is only a single umbilical artery. What are the defects that you should think of? You think of genitourinary defects, particularly defects related to the kidneys. Or you can think of a congenital gastrointestinal defect, or you can think of a congenital heart disease. So these are the congenital defects that you can suspect whenever there is a single umbilical artery. Either there is a congenital kidney disorder, or there is a congenital gastrointestinal disorder, or there is a congenital heart defect. These three types of defects should always be suspected whenever there is a single umbilical artery. If all the three options are given, probably the single best option should be a congenital kidney disorder. It may be a horseshoe kidney, it may be a kidney which is absent, it may be a kidney which is lower than normal, it may be a kidney which is higher than normal. It can be any type of a congenital kidney disorder. But suspect a congenital kidney disorder, especially when there is a single umbilical artery. And when does an umbilical cord fall? This again is a very, very important MCQ. When does the umbilical cord fall? The umbilical cord normally falls by 7 to 10 days. So what is the time when umbilical cords normally falls? the umbilical cord normally falls by 7 to 10 days. So what is the time when umbilical cord falls? Umbilical cord normally falls by 7 to 10 days. This is the time when the umbilical cord normally will fall. So what are the things that you need to remember for an umbilical cord? Two umbilical arteries, one umbilical vein, usually falls by 7 to 10 days after birth. Please remember, you do not need to apply anything at the area where an umbilical cord has fallen. Just keep that area dry. And when you see a single umbilical artery after birth, so the moment the child is born, the umbilical cord is cut, and before clamping you see how many arteries and how many veins you can see in the umbilical cord. Suppose you do not see two umbilical arteries, you only see one umbilical artery. Which are the congenital disorders you should think of? You should think of a congenital kidney disorder or a genitourinary disorder, or you should think of a congenital gastrointestinal tract disorder, or you think of a congenital heart disorder. CHD is a congenital heart disorder. Another thing that we normally see when the umbilical cord falls is a small hernia which may appear, and you can see a small hernia which has appeared at the place where the umbilical cord has fallen. A small portion of the content has appeared from the umbilical ring. Do you need to do any intervention for an umbilical hernia? Please remember, in majority of cases, no. Why? The reason is because in majority of cases, the umbilical hernia may resolve on its own, usually by 10 weeks, may take slightly longer also. However, in majority of cases, umbilical cord, once it falls and an umbilical hernia, once it forms, you do not need to do any treatment. So suppose they ask you a question in the exam, the umbilical cord has fallen, at 2 weeks, a small ring can be seen at the umbilical area, a small hernia can be seen at the umbilical area. What is the next line of treatment? The next line of treatment is nothing, just reassurance of the mother. Only thing that you need to remember is, in some cases, the umbilical ring may be more than 1.5 centimeters in diameter. So suppose the umbilical ring is more than 1.5 centimeters in diameter. This is the umbilical ring. This is the umbilical ring. Suppose the umbilical ring is more than 1.5 centimeters in diameter. Yes, in those cases, surgery may be recommended after 2 years. Reason being very simple, that in such cases, usually it is unlikely that this hernia will resolve on its own. Majority of cases, it resolves on its own. It's unlikely that this hernia will resolve if the umbilical ring size is more than 1.5 centimeters. Right? So, does an umbilical hernia require any treatment? Answer is no. Why? Because it resolves on its own. What's the time when it normally resolves? Majority of cases, it resolves by 10 weeks. However, when a surgery indicated, if the umbilical ring size is more than 1.5 centimeters, especially after 2 years of age, in those cases, this hernia is unlikely to resolve on its own. So it is most likely that this child requires a surgery for umbilical hernia. Next, we come to Apgar score. Now, Apgar score is one of the most common evaluation system for a newborn's well-being after birth. So whenever a child is born, one of the best scores to evaluate the child, whether the child is fine, the child is doing good, and what are the long-term neurodevelopmental outcomes. Long-term neurodevelopmental outcomes that can be found out by the Apgar score. So Apgar scoring system is basically a scoring system for a newborn, and this scoring system helps in evaluation the condition of a newborn. Now, as the name suggests, Apgar, Apgar, as the name suggests, Apgar, there are 5 components of the Apgar. What are the 5 components of the Apgar? The first component of the Apgar is appearance. A stands for appearance of the child. So what is A standing for? A is standing for the appearance of the child. Then P stands for the pulse of the child. So what does P stands for? P stands for the pulse of the child. Then what does G stands for? A, P, G, A, R. So what does G stands for? G stands for grimace. G stands for grimace. Grimace is a type of a smile that can be seen in a newborn at birth. Remember, it is not a social smile. It's a type of a smile and a type of a reflex irritability. So it's a type of a reflex irritability. How do you check for a grimace? You take a feeding tube at birth. You take a feeding tube and try to pass it through the nose of the child and just see how the child is responding. Take a feeding tube, a small tube, and pass it through the nose of the child and just see how the child is responding. That is how you check for the presence of the reflex or the grimace of the child. So A, appearance, P, pulse, G, grimace, then another A stands for activity of the child. In short, tone of the child. How is the child lying in front of you? Is the child having flexion at all the joints? So his hands are rolled up like this, his legs are rolled up like this. Or the child is having extension at the hands but flexion of the legs. Or the child is having extension of the hands and the extension of the legs also. That is how you see the activity or the tone of the child. And finally, R stands for respiration. So what are the components of APGAR? A stands for appearance, P stands for pulse, G stands for grimace or reflex, another A stands for activity, and R stands for respiration. That is why the name APGAR, A-P-G-A-R. Now, how do you rate or score the child? The scoring system that is normally used is scored like this. So we normally keep a score of 0, 1, and 2. Now, how are we scoring the child? First, see the appearance of the child. Suppose the child appears to be totally blue. We give him a score of 0. He's totally cyanosed. Suppose the child's hands appear to be cyanosed, blue, but overall the child is pink. Hands, acro. Acro means hands. And cyanosis means blue. So, acrocyanosis. Suppose the child is having acrocyanosis. Acrocyanosis, what does it mean? Acrocyanosis means the hands of the child are blue. Acral means extremities. Hands are blue. Overall, the child is pink. Give him a score of 1. And if the child appears to be totally pink, give him a score of 2. So this is how you are scoring when you take appearance into consideration. Next, pulse. Just measure the heart rate of the child. And what is the best way to measure the heart rate? Not by feeling the pulse, by putting a stethoscope over the heart and counting the heart rate. Suppose you do not feel any heart rate, 0. Heart rate is 0. Give him a score of 0. Suppose the heart rate that you count is less than 100 per minute. Give him a score of 1. And suppose it is more than 100 per minute. Suppose it is more than 100 per minute, give him a score of 2. So 0 heart rate, give him a score of 0. Less than 100 per minute, it is 60, it is 50, it is 70, it is 80 per minute, give him a score of 1. And if the heart rate is more than 100, give him a score of 2. Next, how do you check for grimace? I told you, take a feeding tube and try to pass it through the nose of the child. You are passing a feeding tube through the nose of the child and there is no response at all. You keep on passing the feeding tube, no response at all. So no response on passing the feeding tube, give him a score of 0. You pass a feeding tube, and the moment you pass a feeding tube, the child appears to be smiling. As I just now told you, this smile is known as a grimace. However, this is not a social smile. I yesterday told you in milestones, when does a social smile appear? It is 6 to 8 weeks. So this is not a social smile. A child learns to have a social smile only at 1.5 months. But if you pass a feeding tube and it appears that the child is having a smile, which is also called as a grimace, give him a score of 1. And suppose you pass a feeding tube, that is a tube through which you give the feed to the child. You pass a feeding tube and suppose the child coughs or sneezes. Suppose the child coughs or sneezes, give him a score of 1. Give him a score of 2. So take a feeding tube, pass it through the nose, no response, score of 0. The child appears to be smiling, score of 1. And the child coughs or sneezes when you pass the tube through the nose, give him a score of 2. Next, see the activity. How is the child lying on the table? The child is lying with his hands extended and the legs extended. There is no flexion present in any part of the body. So no flexion at the hip joint, no flexion at the elbow joint, no flexion at all. Give him a score of 0. No flexion at any part of the body. Give him a score of 0. There is some flexion, not at all the joints, but at least some flexion which is present. Give him a score of 1. For example, the hands are rolled up like this. There is flexion at the elbow joint, but the knees are extended, so the knees are lying limp. Or the hands are lying limp, extended, but there is flexion. The legs are rolled up over the abdomen. So give him a score of 1. And how does a normal term child lie? A term child lies with flexion at all the joints of the body. So his legs will be rolled up over the abdomen. His hands will be rolled up like this. So flexion at elbow joint, flexion at hip joint, flexion at knee joint. So flexion at all the joints of the body, all joints flexion. Give him a score of 2. All flexion means all joints are showing the flexion. And in fact, if you try to extend the hand of the child or extend the legs of the child will resist this extension. So much is the hands flexed that if you try to extend, the child will not allow you. The hands will go back into a flexion stage like this. This means the child's tone is absolutely normal. Give him a score of 2. Finally, respiration. So now you are counting the heart rate, but you are not counting the respiratory rate. This is very important. Just see the respiration. There is no breathing at all in the child. No breathing at all. Give him a score of 0. There is irregular breathing. Irregular breathing. Fast breathing, then suddenly apnea. No breathing at all. Then fast breathing, then suddenly apnea. Give him a score of 1. And there is a normal regular breathing. Normal regular breathing. Give him a score of 2. Normal regular breathing. That is how normally the children breathe at birth. And what should be the respiratory rate? 40 to 60 per minute. So normal regular breathing. Give him a score of 2. I'll just repeat it again. See the appearance. The child is totally blue, score of 0. The child's hands are blue, but the child overall is pink. Acrocyanosis, give him a score of 1. And if the child appears to be totally pink, including the body and the hands and the legs, give him a score of 2. Check pulse. Now in pulse, you are not checking the pulse, you are putting a stethoscope over the heart of the child and count the heart rate. Please remember, you are not counting the respiratory rate, you are counting the heart rate. So a heart rate which is 0, give him a score of 0. A heart rate which is less than 100 per minute, give him a score of 1. And if the heart rate is more than 100 per minute, give him a score of 2. Last column is a score of 2. Then grimace. Take a feeding tube and pass it through the nose of the child. You keep on passing the feeding tube and there is no response at all. Score of 0. You pass a feeding tube, it appears as if the child is smiling. Score of 1. Grimace, score of 1. And you pass a feeding tube and the child suddenly sneezes or suddenly coughs. Give him a score of 2. Activity or the tone of the child. Just see how the child is lying. The child is lying with all joints extended. So hands extended, leg extended. There is no flexion at any joint. Give him a score of 0. Partial flexion at some places. So hands are rolled up like this, or the legs are rolled up, but the hands are extended. Or hands are rolled up like this, legs are extended. So flexion, but only at some joints. Give him a score of 1. And if there is flexion at all the joints of the body, hands are rolled up like this, legs are rolled up like this, and suppose you try to extend the hand at the elbow joint, the child resists extension and rolls up his hands like this again. This means a score of 2. Okay, so this means a score of 2. And last, respiration. There is no breathing at all. Give him a score of 0. There is irregular breathing, give him a score of 1, and there is normal regular breathing, give him a score of 2. So maximum score of 2 for appearance, maximum score of 2 for pulse, maximum score of 2 for grimace, maximum score of 2 for activity, and maximum score of 2 for respiration. So finally, what is the total score? The total maximum score that you give is out of 10. Maximum score that you give is out of 10. Any child who scores between 0 to 3 out of 10, the child is considered to be severely depressed. He is severely depressed. This child requires serious intervention. Any child who scores between 4 to 7 out of 10 is moderately depressed. Or you can say mildly depressed. He's not severely depressed. He's either moderately depressed or he's mildly depressed. And if the child's score is more than 7 out of 10, this child is a normal child. So you can transfer the child to the mother. So you understand, there are 3 types of categories of scoring. If the child scores 0, 1, 2 or 3 out of 10, this child is at a danger of serious complications. He should immediately be transferred to the nursery. He is a severely depressed child. If the child is actually having an Apgar score of 4, 5, 6 or 7, 4 to 7 out of 10, this child is either having a mild depression or is having a moderately depressed child. He is not a normal child, but he is not severely depressed also. He is either mildly depressed or moderately depressed. And if the Apgar score is more than 7 out of 10, that means an Apgar of 8 out of 10, 9 out of 10 or a 10 out of 10. 10 out of 10 is very rare. But 8 out of 10 or 9 out of 10, this child appears to be a normal child. You can transfer the child to the mother. So this is how the scoring of the Apgar is done. The last thing that I would like to tell you is when is the Apgar calculated? The Apgar score, please remember, is calculated at 1 minute and at 5 minutes. Apgar score is never calculated at birth. So when do we start calculating the Apgar score? Appearance, pulse, grimace, activity, tone. So we are calculating the Apgar score. But do we start calculating the Apgar score immediately at birth? Answer is no. We normally calculate the Apgar score at 1 minute and 5 minutes. Important thing is, please hear this carefully. Important thing is, suppose the Apgar score at 1 minute and 5 minutes is less than 7. Suppose it is less than 7 at 1 minute and at 5 minutes. So even at 5 minutes when you see the Apgar score, it is less than 7. Then you have to do an extended Apgar score. Extended Apgar score means that now you need to calculate the Apgar even beyond 5 minutes. So extended Apgar score then should be calculated at 10, 15 and 20 minutes. So what is the indication of doing an extended Apgar score? The indication of doing an extended Apgar score is when the Apgar score originally done at 1 and 5 minutes is less than 7. Then you have to do an extended Apgar score at 10 minutes, 15 minutes and 20 minutes. That means at intervals of 5 minutes each. So I hope this is very clear now. Apgar score calculated at 1 minute and 5 minutes. Total of 5 important components: appearance, pulse, grimace, activity, tone. Scoring done 0, 1, 2. Maximum score therefore 10. If out of 10, the child scores between 0 to 3, the child is severely depressed. If the child scores between 4 to 7, the child is either having mild or having moderately depressed child. Or if the Apgar score is more than 7, either 8, 9 or 10 out of 10, then the child is a normal child. You can shift the child to the mother. When is the Apgar scoring calculated? At 1 minute and 5 minutes. Do we calculate the Apgar even after 5 minutes? Very rarely. When the Apgar score at 1 and 5 minutes is less than 7, then you have to calculate the Apgar score beyond 5 minutes also, that is at 10, 15 and 20 minutes. This form of Apgar is known as extended Apgar scoring. Right? So this is all about Apgar scoring. I hope you have understood Apgar scoring. Let us come back to our slide now. So as I told you, if the Apgar score is less than 3, the child will be called as severely depressed. If the Apgar score is between 4 to 7, the child will be called as moderately depressed. And if the Apgar score is more than 7, the child will be called as a normal child. Right? So this I have already told you. And the maximum score is out of 10. The next topic that we do here is a congenital diaphragmatic hernia. Now, what is a congenital diaphragmatic hernia? A congenital diaphragmatic hernia is basically a type of a hernia or herniation of the abdominal contents through a defect in the diaphragm. So, abdominal contents through a defect in the diaphragm enter into the chest cavity, and once they enter into the chest cavity, they start compressing the lungs. You can see here the picture, you can see the picture here. So, the abdominal contents have entered into the chest cavity, which includes the stomach, which includes the intestine, and they have entered into the chest and are compressing the lungs. So when the lungs are getting compressed, obviously the child cannot breathe. So most of these children will present with breathing difficulty after birth. Any child who presents with a breathing difficulty after birth, especially if associated with a scaphoid abdomen, you can see a scaphoid abdomen, this is a scaphoid abdomen. Scaphos means boat. So if an abdomen is like this, scaphos means like a boat, turned inside. If the abdomen is turned inside. Now, when will the abdomen be turned inside? Obviously, because the abdominal contents have gone up. So therefore, the anterior abdominal wall dips inside. So any child who has a breathing difficulty with a scaphoid abdomen, always think of a congenital diaphragmatic hernia. And how are the abdominal contents enter into the chest cavity? Because of a defect in the diaphragm. Please remember, the defect in the diaphragm can either be a posterolateral defect. That means a defect in the diaphragm which is present in the posterior and the lateral part, most commonly on the left side. This defect is known as the Bogdelek defect, and therefore this hernia will be known as the Bogdelek hernia. So what is the Bogdelek hernia? Bogdelek hernia is a type of a diaphragmatic hernia that is herniating through a posterolateral defect in the diaphragm, particularly on the left side. Majority of cases it is on the left side. So it is not on the right side, it is on the left side. So it is the left lung which is getting actually compressed. Almost 75% of diaphragmatic hernias are Bogdelek hernias. Another type of defect through which this hernia can occur is basically anterior and right-sided defect. So this defect is not posterior, this defect is in the anterior part of the diaphragm and not on the left side but on the right side. Left-sided defects are Bogdelek defects, right-sided defects are Morgagni defects. That is why this type of hernia is also known as Morgagni hernia. So about 22% of diaphragmatic hernias are Morgagni hernias. They are not posterior, they are anterior and they are present on the right side. And only about 2 to 3% are central hernias. So when I say central hernias are neither anterior nor they are posterior, but they are in the central part of the diaphragm, near the esophageal hiatus. That is from where the esophagus enters into the chest cavity. So please remember, diaphragmatic hernias, majority of cases, 75% of cases are arising from which defect in the diaphragm? The Bogdelek defect. The Bogdelek defect or the Bogdelek foramen is the foramen which is present in the diaphragm, which is posterolateral and is on the left side. So any hernia which passes through the Bogdelic foramen will be known as the Bogdelic hernias. About 20 to 22% of hernias do not pass through the Bogdelic foramen but pass through the Morgagni foramen. Morgagni foramen is present in the anterior part of the diaphragm, usually on the right side. Bogdelic foramen is usually on the left side. Morgagnis are usually on the right side. This type of hernia, diaphragmatic hernia, is known as the Morgagni hernia. And about 2% or 3% hernias maximum, diaphragmatic hernias, are central hernias. So if you find a chest X-ray showing that the abdominal contents have entered into the chest cavity, and in majority of cases you are seeing it is the left lung which is getting compressed, that means the hernia is on the left side, it is more likely to be a Bogdelic hernia. On the other hand, if you see the hernia is usually on an X-ray seen on the right side, it is compressing the right lung, it is more likely to be a Morgagni hernia. Morgagni hernias are usually on the right side, Bogdelic hernias are usually on the left side. Both of them, along with central hernias, are type of congenital diaphragmatic hernias. Why are they called congenital? Because most of them are due to defects which are congenitally present in the diaphragm. So the abdomen contents are entered into the chest cavity and are compressing the lungs. Right? So this type of a hernia is known as a congenital diaphragmatic hernia. Now please try to understand again what I am saying. I'll come back to that slide, previous slide, but just pay attention to what I am saying. Because a congenital diaphragmatic hernia is present before birth, it's a congenital disorder, so it is present before birth. A fetus will have this diaphragmatic hernia, and fetus, whenever he has this diaphragmatic hernia, the fetus lungs are getting compressed, and abdominal contents, please understand, the abdominal contents from the abdomen have now entered into the chest of the fetus. So the fetus esophagus is getting compressed. The abdominal contents have entered into the chest and are compressing the esophagus of the fetus. So when the esophagus of the fetus is getting compressed, esophagus is getting compressed, the fetus who is inside the amniotic fluid will not be able to take in the amniotic fluid. You know, the fetus takes in the amniotic fluid, the urine output is formed, and this urine output contributes to the amniotic fluid. So that is how it works. The fetus takes in the amniotic fluid inside the mother's womb, the urine is formed, the urine output contributes to majority of the amniotic fluid. So this fetus now, because its esophagus is getting compressed by the abdominal contents, this fetus is not able to take in the amniotic fluid. It is why amniotic fluid keeps on forming, but the fetus is not able to take in the amniotic fluid, as a result of which the amniotic fluid keeps on increasing. And therefore, one of the defects which is very, very commonly seen in congenital diaphragmatic hernias is polyhydramnios. Polyhydramnios means a complication of pregnancy when there is excess amount of amniotic fluid. So which is the complication of pregnancy which is commonly seen in a congenital diaphragmatic hernia? The most common pregnancy complication is a polyhydramnios. Because this is a congenital disorder, it is likely to be associated with many other congenital disorders. So please remember, congenital diaphragmatic hernias, almost 60% children have other congenital disorders. And I remembered for my exams like this, you can remember for your exams like this, most of the congenital defects, please hear carefully what I am saying. Umbilical artery, a few minutes back, single umbilical artery, which are the defects you will think of? You will think of a congenital kidney disorder, a congenital gastrointestinal disorder, or a congenital heart defect. The same three congenital disorders can be suspected whenever there is a diaphragmatic hernia also. So which are the congenital defects you will expect to be present along with the diaphragmatic hernia? Kidney disorders, gastrointestinal disorders, and heart defects. However, in cases of single umbilical artery, I told you congenital kidney disorders are most common. In the case of a congenital diaphragmatic hernia, congenital heart defects are very common. Almost 60% of children, this is very important, Almost 60% of children who have a diaphragmatic hernia also have a congenital heart disease. So we do it routinely in our setup. Whenever there is a diaphragmatic hernia, an echocardiography of the newborn should also be performed, because you may suspect the presence of a congenital heart disease along with a diaphragmatic hernia. Because the lungs are getting compressed, the lungs have not expanded, most of these children suffer from pulmonary hypoplasia and pulmonary hypertension is the cause of death in maximum number of cases. Pulmonary hypoplasia, hypo means not able to develop properly because the lungs are compressed, so lungs cannot expand. So pulmonary hypoplasia, and as a result of pulmonary hypoplasia, pulmonary hypertension is the most common cause of death in a diaphragmatic hernia. I'll just explain this once again. See, just pay attention here. Normally, the lungs in a fetus are in a collapsed state. They are not performing the oxygenation function, and most of the pulmonary vessels are in a state of vasoconstriction, as a result of which pulmonary hypertension is normally present in the fetus. So this is happening in a fetus. The lungs are in a collapsed state. The lungs, because they are in a collapsed state, the pulmonary vessels are vasoconstricted, narrowed down. And because of this, because the pulmonary vessels are vasoconstricted, the pulmonary pressures are very high. So it's normal to have a state of a pulmonary hypertension during the fetal life. It's normal. Pulmonary pressures are very high in the fetus, which is normal. That is why they do not allow the blood to enter into the lungs, because the high pulmonary pressures, blood does not enter into the lungs in the fetus. But there is nothing to worry, because in the fetus, lungs are not performing oxygenation. It is the placenta which is performing oxygenation. So there is nothing to worry. Now what happens is, after birth, what happens is, suddenly the child starts taking in air. He cries and the child starts taking, the newborn takes in air. As soon as the newborn takes in air, there is increase in oxygen concentration, because now the child is breathing high amount of oxygen in the atmosphere. The oxygen which is present in the intrauterine environment is very low, but the oxygen concentration which is present in the extrauterine environment outside is 21 to 22%, so it's very high. So the child starts breathing high amount of oxygen the moment the child is born. And the moment there is high oxygen concentration, what will happen is there will be gradually pulmonary vasodilatation. So it was pulmonary vasoconstriction. It was pulmonary vasoconstriction in the fetus state, and it becomes pulmonary vasodilatation in the neonatal state. That means after birth. So now after birth, it becomes there is pulmonary vasodilatation. And when there is pulmonary vasodilatation, what happens is, now the pulmonary pressure starts to fall. So what is contributing to this fall in the pulmonary pressures after birth? What is contributing to the, see the diagram that I have made? What is contributing to the fall in the pulmonary pressures after birth? It is the high oxygen concentration that the child is breathing. Suppose after birth, the child continues to have respiratory distress. So he is not able to take in the high amount of oxygen that is present in the environment. Oxygen is present in the environment, but because of respiratory distress, the child cannot take in that high amount of oxygen. So this pulmonary vasodilatation, which you can see, I have marked in red, this pulmonary vasodilatation and the fall in pulmonary pressures, which should happen after birth, it never happens. And therefore, pulmonary hypertension, please hear carefully, pulmonary hypertension, which was present in the fetal life normally, persists even after birth. Until the time pulmonary hypertension persists after birth, it will not allow the blood to enter into the lungs. So I told you, in the fetal life, blood is not able to enter into the lungs. It was fine because it was placenta which was performing the purification of the blood. But what after birth? Now, if the blood is not allowed to enter into the lungs, there is no placenta. So this child will keep on having deterioration of his breathing efforts and will ultimately die. So the most common cause of death, I hope you have understood, the most common cause of death in a child of congenital diaphragmatic hernia is persistence of pulmonary hypertension even after birth. This condition is sometimes also known as, what is the name of this condition? Persistence of pulmonary hypertension even after birth. What is this condition called? It is also known as persistent pulmonary hypertension of the newborn. What is this condition called? It is known as persistent pulmonary hypertension in the newborn, also in short called as PPHN. PPHN, persistent pulmonary hypertension of the newborn. In fact, this condition, persistent pulmonary hypertension of the newborn, does not only occur in a diaphragmatic hernia, it can occur in any condition in which the child is not able to breathe properly after birth. Because if the child is not able to breathe properly after birth, the child will not be able to take in oxygen. And if the child is not able to take in oxygen, that pulmonary vasodilatation which should have happened after birth and that pulmonary pressures that should have fallen after birth, that never happens. So the pulmonary pressures remain very high, and that is why we say persistence of pulmonary hypertension after birth. So therefore, PPHN, persistence pulmonary hypertension of the newborn. And this is the cause of death in maximum number of cases which present with breathing difficulty after birth. So one of the condition is diaphragmatic hernia. So congenital diaphragmatic hernia, the most common cause of death is pulmonary hypoplasia. That means the lungs do not expand after birth because the lungs are getting compressed by the abdominal contents, and as a result, persistent pulmonary hypertension of the newborn. I hope you have clearly understood now. So if someone asks you what is the most common cause of death in a child who has congenital diaphragmatic hernia, most common cause of death after birth, it is either a pulmonary hypoplasia. Just see the options, either a pulmonary hypoplasia, which is one option, or pulmonary hypertension. This pulmonary hypertension should not have been present after birth. The pulmonary pressures should have fallen so that now the blood can enter into the lungs. But if it keeps on persisting, this is highly dangerous and can be a cause of death after birth. What is this condition called? Persistent pulmonary hypertension of the newborn. Right? Suppose this child comes to you. How do you manage this child of persistent pulmonary hypertension of diaphragmatic hernia? So how do you manage this child? How do you manage a child of diaphragmatic hernia? We have done till here. Common cause of death is pulmonary hypoplasia and pulmonary hypertension. So what is the management? The first thing is intubate the child. Normally, when you are doing a neonatal resuscitation, the first thing that you would like to do is a bag and mask ventilation. Ambu bag, apply it over the face and start bag and mask ventilation. But please remember, bag and mask ventilation can be very, very dangerous in these children. Why? Because when you are doing an ambu bag, what you are doing in fact is you are pushing in air into the stomach. And because the stomach right now is not in the abdomen but is in the chest, as you inflate the stomach more and more, the lungs will get compressed more and more. So therefore, do not do bag and mask ventilation. Bag and mask ventilation is contraindicated in a diaphragmatic hernia. This is a very important question. What is the absolute contraindication of ambu bag and mask ventilation in newborn? It is a congenital diaphragmatic hernia. So rather than that, just intubate. I hope you all know what is intubation. Here, a tube, which is also known as an endotracheal tube, is passed through the mouth of the child into the chest cavity, into the, not chest cavity, into the respiratory tract. So now when you are pushing in air, you are pushing in air only into the respiratory tract. You're not pushing in any air into the gastrointestinal tract. So the stomach will not dilate. This process is known as intubation. Once you have intubated, now whatever air is present in the stomach, you actually have to deflate it. You have to bring that air out. The reason is when the stomach will deflate, inflate is expanding, deflate is collapsing. So if you allow the stomach to deflate, what will happen is the area in the chest cavity will be more and therefore the lungs will be able to expand more. So how do you deflate the stomach? Push in a nasogastric tube. So a feeding tube that is passed through the mouth or through the nose into the stomach, and then you take a syringe and empty out the air from the stomach. So when you are emptying out the air from the stomach, what happens is the stomach collapses, and because the stomach right now is in the chest cavity, as the stomach collapses, the lungs will gradually start expanding because they are now getting the space to expand. So they will start expanding, and finally once this thing has been done, then you finally take the child to a surgery. Normally the surgery is performed at 48 to 72 hours after birth. So please remember now, it is not relevant when you are performing a surgery. It's the least important marker, prognostic marker in a diaphragmatic hernia. Least important timing of surgery. In the good old times, we used to do a surgery immediately as soon as the child used to come. Now, the first thing that you need to do is a stabilization of the child. The first thing to be done in a diaphragmatic hernia, make the child stable. And how will you make the child stable? First, intubate so that at least now the child is receiving enough amount of oxygen. Second, deflate the stomach by pushing in a nasogastric tube so that the lungs get more space to expand. And then you do a surgery, which is normally performed between 48 to 72 hours. So it's the least important prognostic marker. In a congenital diaphragmatic hernia, whether the child will survive or will not survive will not depend upon whether you are doing surgery immediately or no. No. If you have stabilized the child, you can perform a surgery even after 48 to 72 hours of birth. There is no problem at all. Only thing is stabilization is very important. There are many other treatment options that are being now tried in these cases. I don't think you need to go into the details of that. You need to manage the pulmonary hypertension which is currently present in the child, because I told you diaphragmatic hernia, pulmonary hypertension is present. So pulmonary pressures need to be reduced. So there is no need to go into the details of that. That pulmonary pressures need to be reduced by different methods. One is nitric oxide. Nitric oxide is a pulmonary vasodilator. So you give inhaled nitric oxide. Then there are various types of prostaglandin 5 inhibitors. Prostaglandin 5 inhibitors such as sildenafil. So that is also a pulmonary vasodilator. So there is no need to go into the details. The basic thing that you need to remember for your exams, how to stabilize a child of a diaphragmatic hernia: intubate, nasogastric tube to deflate the stomach, and a surgery. Timing then surgery is normally performed in these cases. It is 48 to 72 hours after birth. So I hope you have understood this. And if a question comes in the exam, you can answer this question. You can see this is a typical X-ray of a diaphragmatic hernia. You can see the air-filled intestinal loops have entered into the chest cavity. This was one of the FMG questions, a question that was asked, an X-ray that was given, and they asked what is the disorder the child appears to be suffering from. You can see the intestinal loops. You can see the loops of the